Welcome to the Funeral Channel Network podcast. I am so glad you are joining us today.
It's great to be here.
Yeah, and just to be clear for everyone listening, we are doing a deep dive today, and it's a very special presentation because we're exploring something that, well, it really bridges the gap between how we remember the dead and how we actively protect the living.
Right. It's a fascinating intersection.
It really is. So our source material today is this incredible essay provided by the funeral program site. It's titled Thyroid Cancer Awareness, the Meaning of the Blue, Pink, and Teal Ribbon.
Which is such a specific, striking visual.
Exactly. And the mission of this deep dive is to really explore the anatomy of this disease. It's a subtle disease, but we want to look at the modern paradox of why diagnoses are rising and, how the grief of a funeral is actually being transformed into a public health tool.
Yes. We're essentially talking about the human body, medical technology, and our digital legacies all colliding.
Okay, let's unpack this because I want you to imagine just for a second standing in a memorial space.
Okay, picture that.
Right. It's a room traditionally dressed in, somber blacks, muted grays, maybe some subtle whites.
Very muted, very quiet aesthetic.
Exactly. You're holding a funeral program, preparing yourself for that passive experience of mourning, and then suddenly your eye is caught by this bright, complex ribbon woven directly into the design of the page.
It really jolts you out of that headspace.
It does. It's not a single solid color. It's this vibrant interlocking of blue, pink, and teal.
Right.
It disrupts the visual expectation completely. I mean, it's not just a decoration. It's almost like a public health warning masquerading as a tribute.
What's fascinating here is the immediate cognitive dissonance it creates.
Cognitive dissonance. Yeah, explain that a bit more.
Well, you were there to grieve an ending, right? But that tricolor symbol, it forces your brain to engage with the present, and more importantly, with your own physical vulnerability.
Oh, wow.
Yeah, it's a very deliberate disruption of the mourning process.
And that disruption is kind of the genius of it, isn't it? The funeral program site integrates this specific design into printed materials like funeral programs and memorial cards.
Which serves two purposes.
Right. It honors a specific life, but it also casts a really wide net of awareness to everyone in the room.
We really need to look at the semiotics of that design choice, honestly, because most awareness campaigns, they rely on monolithic branding.
Like the pink ribbon.
Exactly. You see a solid pink ribbon, you instantly map it to breast cancer. You see a puzzle piece, you map it to autism awareness.
Right. It's a shortcut.
It's about creating a unified, instantly recognizable cognitive shortcut. But splitting this ribbon into three distinct colors, the blue, pink, and teal, it actively resists that shortcut.
It makes you stop.
It demands a second look.
But wait, from a marketing standpoint, isn't that a mistake? I mean, if the goal is immediate public recognition, why not just pick teal and stick with it?
You'd think so, right?
Yeah, like why force the public to memorize a tricolor scheme? Doesn't that just complicate the message?
It does complicate it, but necessarily so. Because a single color implies a single monolithic experience.
Oh, I see.
And biologically, thyroid cancer is anything but monolithic. The design is deliberately complex because it reflects the incredibly diverse nature of the disease itself.
Okay, that makes a lot of sense.
Right. If you use a single color, you are subtly telling the public that, that thyroid cancer is one unified condition with a standard progression.
And a standard treatment, which it isn't.
Exactly. The three colors visually insist on complexity. It's a literal representation of medical diversity woven right into the fabric of the campaign.
So the ribbon isn't just a logo, it's an educational primer.
Pretty much, yeah.
I mean, the moment someone at a memorial service looks at that program and asks the person next to them, hey, why are there three colors? The campaign has won.
They've successfully breached the defenses.
Right. The person is now actively engaged in learning about the pathology.
It forces the mourner to look inward. You're processing this really heavy emotional load of a funeral, but simultaneously, you're absorbing a highly specific health directive.
Which is a heavy cognitive load for anyone to carry in that environment.
It is.
But think about the last memorial service you attended. Just, put yourself back in those folding chairs. You're reading a beautiful eulogy, and right next to the dates of birth and passing is this bright anchor of blue, pink, and teal.
It's silently asking you to check your own neck.
Exactly. And to look at the people sitting next to you and wonder about theirs. It bridges the gap between the deceased and the living in a really tangible way.
And to understand why that bridge is so necessary, we really have to pull back from the psychology of the memorial for a second.
Okay, where are we going?
We have to look at the physiological ground zero, the anatomy of the thyroid gland itself.
Ah, yes, the butterfly in the neck.
Exactly.
It's located right at the base of the neck, right? Wrapping around the trachea.
Right at the front there, yes.
And the source material points out that despite being incredibly small, I mean, it usually weighs less than an ounce.
Barely anything.
Yeah, but it is essentially the master engine of the human body. It produces the hormones that regulate metabolism, heart rate, and body temperature.
Let's break down the mechanics of that, because regulates metabolism is one of those phrases we throw around a lot in health circles.
Oh, totally. People say I have a slow metabolism all the time without knowing what it means.
Exactly. But we really need to unpack the immense physiological stakes here. The thyroid is the core of what we call the hypothalamic pituitary thyroid axis.
That's a mouthful.
It is, but simply put, it's taking orders from the brain and pumping out thyroxine, which is T4, and tritothyronine, which is T3.
Okay, T3 and T4.
And these aren't just like subtle mood regulators. These hormones are literally dictating the mitochondrial activity in virtually every single cell in your body.
Wait, every single cell?
Almost all of them, yes.
Wow, so they are setting the baseline speed limit for cellular function.
Precisely. They control how quickly your cells burn oxygen and calories to produce ATP.
Which is the energy currency of the body, right?
The actual literal energy currency. So when we say it controls heart rate and body temperature, we mean it is the body's internal thermostat and its throttle.
So what happens if it malfunctions?
Well, if the thyroid downregulates, if it slows down, your core temperature drops. Your heart muscle actually contracts slower.
That sounds dangerous.
It is. Your digestive tract practically halts. Now, conversely, if it upregulates and works too hard, your heart races into palpitations. You burn through your energy reserves at an unsustainable rate.
It's like the invisible conductor of a massive symphony orchestra.
That's a great way to look at it.
Yeah, I mean, as long as the conductor is keeping the right tempo, you don't even notice them.
Right.
The percussion section, which is your heart, keeps a steady beat. The string section, your cellular metabolism, provides the underlying pace.
And the brass section maintains your body temperature.
Exactly. But if the conductor loses the tempo, the whole symphony falls apart. Right now, for everyone listening, this little butterfly-shaped organ is dictating how fast your heart is beating and how warm you feel.
It's a highly functional metaphor, but we have to push it further to understand the pathology of cancer here.
Okay, push it.
Because it's not just that the conductor might speed up or slow down the music. In the case of thyroid cancer, you are dealing with a localized mutiny within the conductor's podium itself.
Oh, that's a chilling image.
The cells responsible for writing the sheet music for the rest of the body begin to replicate uncontrollably.
Right. And here is where we run into a massive biological contradiction. I really want to dig into this.
Okay.
Because this organ is the central command for everything from your heart rate to your cellular energy. You would logically assume that a structural failure, like a tumor growing inside it, would set off massive blinding alarms.
You'd think so.
Yeah, like if the engine block of your car cracks, you know it immediately. There's smoke, there's noise. But that's not what happens here. The source material reveals that the early stages of this disease are remarkably, terrifyingly silent.
Yes. This raises an important question about how we interact with our own bodies. We call it the trap of mild symptoms.
The trap of mild symptoms. Because the indicators are so subtle early on.
Very subtle.
We're talking about a lump or swelling in the neck, which the text explicitly notes may not cause any pain,
Right.
or subtle changes in the voice, difficulty swallowing, or just a persistent cough that has nothing to do with a cold.
Let's talk about the biology of that painlessness, actually, because that is where the psychological trap is really set.
Yeah, why doesn't a lump in the neck hurt? You'd think a tumor would hurt.
Well, the thyroid gland itself doesn't have a dense network of nociceptors inside the tissue.
Nociceptors being pain receptors.
Exactly. The pain usually only comes if a tumor grows large enough or fast enough to rapidly stretch the fibrous capsule surrounding the gland. Or, if it invades surrounding structures.
Yeah.
So a slow-growing nodule can exist and even expand for years without ever tripping the body's primary alarm system.
And here's where it gets really interesting from a behavioral standpoint. We are deeply, fundamentally conditioned to equate severity with agony.
Oh, absolutely.
From the time you are a toddler, you learn that a scraped knee hurts. A broken bone is excruciating. Touching a hot stove causes immediate, intense pain.
It's a survival mechanism.
Right. Pain is our evolutionary green light to seek medical intervention. So if it doesn't hurt, we just categorize it as benign.
We give ourselves false permission to ignore it.
Exactly. You feel a small lump while washing your neck in the shower. You press on it. It doesn't hurt. So your brain immediately downgrades the threat level.
You tell yourself, I'll keep an eye on it.
Yes, I'll keep an eye on it. And because it doesn't hurt the next day or the week after that, it just fades into the background noise of your daily physical existence.
What's the danger isn't just the painless lump. It's the other symptoms, too. The hoarseness, the cough, the swallowing issues.
The tricky ones.
Very tricky, because those are mechanical symptoms caused by the anatomy of the neck. The thyroid sits right on top of the trachea.
A windpipe.
Right, and the esophagus. And tucked right behind it is the recurrent laryngeal nerve, which controls your vocal cords.
Okay, so the tumor isn't necessarily causing systemic chemical chaos early on. It's literally just taking up physical space in a very crowded neighborhood.
Precisely. If it presses on the recurrent laryngeal nerve, your vocal cords can't close properly, so your voice gets hoarse.
Wow.
If it presses on the esophagus, you feel a slight catch when you swallow a pill. If it irritates the trachea, you develop a dry, persistent cough.
And think about how easily we rationalize those mechanical symptoms. I mean, how do we separate the mundane from the malignant without becoming total hypochondriacs?
This is difficult.
You get a hoarse voice and you instantly blame it on talking too loudly in a crowded restaurant last night.
Or a dry winter breeze.
Right. You get a persistent cough and you blame pollen or allergies or just getting older. We are masters of domesticating our symptoms.
We really are. We find the least terrifying explanation for physical anomalies and we just cling to it.
Which is why the text emphasizes regular medical checkups. Routine evaluation is kind of the only effective countermeasure here.
It is. You cannot rely on your subjective experience of your body to detect this early. Your subjective experience is completely compromised by the lack of pain and the ease of rationalization.
So it requires objective clinical palpation and imaging. A doctor actually feeling your neck.
Exactly. Clinical intervention.
Which transitions us perfectly into one of the most debated, fascinating aspects of modern endocrinology.
The diagnostic paradox.
Yes, because finding these subtle clues early is crucial, and as the source points out, we're suddenly finding a lot more of them than we used to. Diagnoses have been steadily increasing over recent years.
If we connect this to the bigger picture, it's a classic epidemiological puzzle.
Yeah.
You have to separate incidence from detection.
Right. Are cancer rates actually spiking, or are our advanced cameras just finally good enough to see what was always there?
That's the million-dollar question. On one hand, the increase is heavily attributed to improved detection methods.
Like ultrasounds.
High-resolution ultrasounds are now so sensitive they can spot nodules the size of a peppercorn.
A peppercorn?
Yes. Nodules that a doctor's fingers would never feel during a routine physical, and that the patient would certainly never notice.
So it's the double-edged sword of advanced imaging.
It is. We've effectively built a microscope so powerful that we are finding diseases that might never have actually progressed to cause clinical harm in a patient's natural lifespan.
Right.
It introduces the concept of overdiagnosis.
Mm.
We are labeling people as cancer patients for microcarcinomas that are incredibly slow-growing.
But I want to make sure we don't just blame the better flashlights for finding more tumors, because the text explicitly mentions environmental, genetic, and lifestyle factors.
It does, yes.
And as a curious listener, I'm wondering what it is about modern life that might be triggering this specific butterfly-shaped gland. Is the actual underlying rate of disease increasing?
I agree we shouldn't dismiss environmental factors, but we need to be highly specific about what the data actually says.
Okay, what does it say?
We know ionizing radiation is a proven environmental trigger.
Radiation. Okay.
If you look at historical data from populations exposed to high levels of radiation, whether through medical treatments in childhood or environmental disasters, the spike in thyroid malignancies is undeniable.
So the thyroid is uniquely vulnerable to radiation.
Extremely vulnerable.
But what about modern daily environmental factors? I mean, we are living in a chemical soup that our grandparents didn't experience.
It's true.
We're constantly exposed to endocrine-disrupting chemicals in plastics, in agricultural runoff, in our diets. Given that the thyroid is the core of the endocrine system, Isn't it logical to suspect that environmental stressors are aggravating this specific gland?
It's a highly active area of epidemiological research,
Yeah.
and I want to be careful to impartially report the theories here without taking a definitive stance because the science is ongoing.
Here.
But the theory is that the thyroid acts as a chemical sponge for the body. For example, the gland requires iodine to synthesize hormones.
Right.
If environmental factors interfere with iodine uptake, or if chemical disruptors mimic thyroid hormones and confuse the feedback loop, the cellular stress on a gland increases.
And sustained cellular stress is the breeding ground for genetic mutation.
Exactly. That is the biological hypothesis being investigated.
So it's potentially a perfect storm. We have an environment that may be increasing the baseline cellular stress of the gland, combined with imaging technology that can spot a resulting mutation almost the moment it happens.
It's no wonder the diagnoses are climbing.
Right. But for anyone listening who might be feeling a bit of information overload or anxiety about these health risks, we should reiterate that while diagnoses are up, so is the effectiveness of early detection.
Absolutely. Finding it early, even if it introduces the anxiety of overdiagnosis in some cases, generally yields highly favorable outcomes.
But once those advanced imaging technologies find a tumor, the next step isn't a one-size-fits-all solution.
No, not at all.
Which brings us back to the meaning of that multicolored ribbon. We are talking about one umbrella name, thyroid cancer.
But four vastly different biological enemies.
Exactly, papillary, follicular, medullary, and anaplastic. We really need to unpack the cellular mechanics of these four distinct types to understand why the text insists on personalized care.
A monolithic approach to cancer completely fails here.
It's like hearing the words thyroid cancer is akin to hearing the word weather. It's just an umbrella term.
I like that analogy.
Right, like papillary might be a rainstorm, while anaplastic could be a Category 5 hurricane. You wouldn't prepare for both the same way.
You definitely wouldn't. Let's start with the rainstorm then. The most common type, which accounts for the vast majority of diagnoses, is papillary thyroid carcinoma.
Okay, so if we think of the thyroid gland as a highly specialized biochemical factory,
Right.
the papillary type is an error originating in the assembly line workers, the follicular cells that actually produce the thyroid hormones.
That's a structurally sound way to look at it. Papillary carcinomas arise from those specific cells, but they are notoriously slow-growing.
Okay, so a slow error.
Yes. They tend to be localized, and when they do spread, they typically move first into the lymphatic system, the local lymph nodes in the neck.
Got it.
Biologically, they maintain a lot of the characteristics of normal thyroid cells, which makes them highly treatable because they still respond to the body's natural regulatory signals to a certain degree.
So that's the first variant, a slow, localized error on the main assembly line. Then we have follicular thyroid cancer, which also originates in those same assembly line cells, but behaves very differently.
Yes, follicular is the second most common. And the key difference here isn't just the appearance of the cells under a microscope, but how they travel.
How so?
Well, while papillary tends to spread through the slow-moving lymphatic system, follicular cancer has a propensity for hematogenous spread, meaning it invades the blood vessels.
Oh, wow, which is a much faster highway.
Exactly. By entering the bloodstream directly, follicular cells have a much easier path to distant organs, particularly the lungs and the bones.
That completely changes the risk profile.
It does. So even though it originates in the exact same type of cell as papillary, the biological mechanism of its spread means you need entirely different vigilance during treatment.
Okay, so papillary and follicular are both derived from the main workforce of the thyroid factory, but the third type, medullary thyroid cancer, is a completely different beast.
Very different.
It doesn't even start in the hormone-producing follicular cells, right?
No, it originates in the parafollicular cells, also known as C cells.
C cells.
Yes. Going back to your factory metaphor, if the follicular cells are the assembly line workers, the C cells are a specialized independent department operating in the same building.
Doing completely different work.
Right. Their job isn't to regulate metabolism. Their job is to produce calcitonin, which is a hormone involved in regulating calcium levels in the blood.
So it's a failure in a completely different biological system that just happens to be housed inside the thyroid gland.
Precisely. And what makes medullary cancer particularly complex is its strong genetic component.
I was reading about this. The hereditary aspect is huge.
It is. A significant percentage of medullary cases are familial, linked to a specific mutation in the RET proto-oncogene. It's often part of a broader genetic syndrome called multiple endocrine neoplasia, or BEN-N.
So wait, this means a medullary diagnosis doesn't just trigger treatment for the patient?
No,
It often triggers genetic screening for their entire extended family?
exactly. It redefines the disease from a solitary event into a familial legacy.
That must be so overwhelming. I mean, think about the emotional burden for a family to learn about these subtypes. You aren't just managing your own health, you are suddenly the sentinel for your siblings and your children.
It's an incredible burden of knowledge to carry, which really reinforces why public awareness campaigns are so necessary to educate people before they are in the doctor's office.
Absolutely. And finally, we arrive at the fourth type, anaplastic thyroid cancer. And from everything in the source material, this is the one that completely abandons the factory blueprint altogether.
Anaplastic is rare, but it is one of the most aggressive and devastating malignancies in the human body.
Biologically, what is happening here? Why is it so much more aggressive than the others? Like, what makes it the hurricane?
The key word is undifferentiated.
Undifferentiated.
Yes, in papillary or follicular cancers, the tumor cells still look and act somewhat like normal thyroid cells. They retain their cellular identity.
Yeah, okay.
In anaplastic cancer, the cells undergo a massive de-differentiation. They lose all structural memory of being thyroid cells. They stop producing hormones, they stop absorbing iodine, they basically abandon all their specialized functions.
They essentially regress into pure chaotic replication machines.
Exactly. They devote 100% of their metabolic energy to rapid, aggressive cellular division and local tissue invasion.
That is terrifying.
They don't wait to slowly travel through lymph nodes and blood vessels. They aggressively bulldoze directly into the trachea, the esophagus, the muscles of the neck. It is a catastrophic biological collapse of the organ's architecture.
So when we look at that blue, pink, and teal ribbon, we are looking at a visual representation of this exact cellular spectrum.
You have to. You cannot treat the slow, localized error of a papillary tumor the same way you treat the genetic systemic threat of medullary or the catastrophic expansion of anaplastic.
The therapies have to be as distinct as the enemies.
Which is why the modern clinical arsenal has evolved so dramatically. We've moved from blunt instruments to highly specific molecular interventions.
Let's walk through that modern arsenal, because the evolution of how we treat this is fascinating, and it's a huge part of the text.
Where should we start?
Let's start with the historic baseline, which is still primarily the first line of defense: surgery, a thyroidectomy. You physically cut the problem out.
Right. And depending on the size and type of the tumor, it might be a partial removal, a lobectomy, or a total thyroidectomy. But we have to acknowledge the anatomical risks here.
Because of the neighborhood in the neck.
Precisely. Surgery in the central neck is essentially working in a biological minefield. The surgeon isn't just removing the thyroid. They are navigating millimeters away from the recurrent laryngeal nerves we discussed earlier.
The ones controlling the vocal cords.
Yes. If they sever or damage that nerve, the patient could suffer permanent vocal cord paralysis.
Wow.
Furthermore, buried on the backside of the thyroid are 4 tiny glands called the parathyroids, which control the body's calcium levels.
And what happens if those get damaged?
If those are accidentally removed or have their blood supply cut off during the thyroidectomy, the patient faces severe, lifelong calcium regulation issues.
So surgery is incredibly delicate. But let's say they perform a total thyroidectomy successfully. They have removed the cancer, but they've also removed the body's master engine. The patient now has no natural way to regulate their metabolism, heart rate, or body temperature.
This is where hormone therapy becomes a lifelong necessity. The patient must take synthetic thyroxine daily.
Just to function.
Yes, but in the context of cancer treatment, this synthetic hormone actually serves a dual purpose. It doesn't just replace what was lost. It actively suppresses the pituitary gland.
Yeah, that is interesting. How does that work? Why do we want to suppress the pituitary?
It's a brilliant manipulation of the body's feedback loop. The pituitary gland in the brain releases thyroid-stimulating hormone, or TSH.
Okay.
TSH acts as a growth signal for any remaining thyroid cells, including microscopic cancer cells left behind after surgery.
Oh, I see.
By giving the patient slightly higher doses of synthetic thyroid hormone than they strictly need, the brain senses there is plenty of hormone in the blood and it shuts down TSH production.
You essentially starve any microscopic, lingering cancer cells of their primary growth signal. You turn off the fertilizer.
Exactly. It's systemic suppression. It's very clever.
But perhaps the most elegantly engineered treatment in this entire landscape is radioactive iodine therapy, or RAI.
Oh, RAI is fascinating.
I marvel at this one. I mean, it sounds like sci-fi. The biological elegance of it is staggering. You are literally administering a radioactive isotope to a patient to hunt down specific cells.
It is a true targeted therapy.
Explain how this Trojan horse actually works at the cellular level, because it just blows my mind.
It relies on a highly specialized protein found almost exclusively on the surface of thyroid cells. It's called the sodium iodide symporter, or NIS.
Okay, NIS.
Normal thyroid cells use this importer to pull dietary iodine out of the bloodstream to build thyroid hormones. It's an active transport mechanism.
They're essentially vacuum cleaners for iodine.
Yes, perfect analogy. And brilliantly, papillary and follicular cancer cells retain this importer. They still want to vacuum up iodine.
Okay, so they're still acting like thyroid cells in that respect.
Exactly. So post-surgery, oncologists administer a pill containing iodine-131, which is a radioactive isotope. The patient digests it, it enters the bloodstream, and every remaining thyroid cancer cell in the body,
No matter where it is.
whether it's in the neck, the lungs, or the bones, it actively pulls that radioactive iodine inside its own cell membrane.
It willingly swallows the poison.
It does. And once inside, the iodine-131 emits beta radiation.
And beta radiation is short range, right?
Very short range. Beta particles only travel a distance of 1 to 2 millimeters, so they don't cause massive systemic radiation damage to the rest of the body. They emit a highly localized, lethal dose of radiation that shatters the DNA of the cancer cell from the inside out, destroying it completely.
It is a microscopic, self-inflicted targeted strike. That is amazing.
It really is.
But wait, this only works for the cancer cells that still retain their thyroid identity, right? The ones that still have those iodine vacuum cleaners? What happens with medullary or anaplastic cells that don't absorb iodine?
That is where the frontier of targeted therapies comes in. This is moving away from radiation and into the realm of molecular biology. For cancers that don't respond to RAI, we now use tyrosine kinase inhibitors, or TKIs.
Okay, TKIs. And how do those differ from the radioactive approach?
Instead of targeting an iodine symporter, TKIs target the specific mutated enzymes inside the cancer cell that are constantly signaling it to divide.
So going after the mutation itself.
Yes, if a cell has a specific genetic mutation, like the RET mutation in medullary, or a BRAF mutation in some aggressive papillary cases, the TKIs bind directly to those mutated proteins and act as a chemical off switch.
Wow.
They block the intracellular signaling pathways, halting the tumor's growth at the molecular level.
We are essentially dismantling the rogue factory from the inside by disabling the exact faulty circuit board causing the overproduction. It's breathtaking precision.
It represents how far medicine has come.
Truly. But, you know, we also have to ground this in the human experience, because the text explicitly highlights the aim of improving patient outcomes and, crucially, quality of life.
And that is the necessary counterweight to all this biological marveling. Surviving the treatment is only the first hurdle. Living with the consequences is a decades-long marathon.
Right. Quality of life means acknowledging that survival isn't the only goal. Living well after cancer is paramount.
Absolutely.
I mean, we are asking a patient to endure the psychological trauma of a cancer diagnosis, the physical trauma of neck surgery, the isolation protocols required during radioactive iodine therapy.
Right, where you literally have to stay away from your family because you are temporarily emitting radiation.
Exactly. And then the lifelong, daily tightrope walk of balancing synthetic hormones. It's not just a medical victory, it's an ongoing chronic management protocol.
It requires an immense amount of resilience from the patient. And tragically, despite the precision of TKIs and the elegance of RAI, we still lose people to this disease.
We do.
Especially to the aggressive variants like anaplastic,
Yeah.
or to distant metastases that eventually evade our targeted therapies.
And that heavy reality brings us to the final and perhaps most culturally profound shift outlined in our source material.
Yes.
When the medical arsenal is exhausted and a life is lost, how we process that grief is evolving just as rapidly as the targeted therapies we just discussed.
It's a huge paradigm shift.
This is the digital afterlife and the legacy of awareness.
We are witnessing a fundamental architectural shift in how human beings memorialize their dead. For millennia, mourning has been tethered to physical geography and specific windows of time.
Right, like a funeral service on a Tuesday.
Exactly. You gathered at a gravesite or in a specific building on a specific afternoon. The memorial was static.
A stone marker. You carve the name, the dates, and it looks backward. It is a closed loop of remembrance.
But the integration of digital platforms, the online guest books, the memorial websites, the social media tributes specifically utilizing these awareness ribbons, It shatters those physical and temporal boundaries.
So what does this all mean? I mean, the funeral program site doesn't just offer physical cards to hand out. They are feeding into an entire ecosystem of digital remembrance.
They are.
When a family incorporates the blue, pink, and teal ribbon into a digital tribute, they are essentially open sourcing their grief.
Let's analyze the sociology of that, because when a digital memorial featuring that tricolor ribbon is published, it enters the architecture of social media feeds. It doesn't sit passively waiting for visitors, it actively travels.
It appears on the screens of close family, absolutely. But it also reaches the periphery of that person's network. It reaches the former colleague they haven't spoken to in a decade. It reaches the distant cousin. It reaches casual acquaintances.
And as it travels across those peripheral networks, the function of the ribbon actually transforms.
How so?
Well, for the immediate family, the ribbon represents the specific battle their loved one fought. It is a symbol of their highly personal trauma. But for the casual acquaintance scrolling through their feed on a Wednesday morning, the ribbon operates purely as a public health intervention.
It is a bright, disruptive visual cue that breaks through the noise of vacation photos and daily trivialities.
Exactly.
It silently demands that the viewer pause and consider their own mortality. It says, hey, this complex, subtle disease took someone connected to you. Are you paying attention to your own body?
We have taken the tools of casual, ephemeral digital networking and infused them with profound, life-saving utility.
It's amazing.
The act of communal mourning becomes a decentralized, viral public health campaign.
And it creates this incredible paradox of legacy. Think about your own digital footprint, right? Platforms meant for sharing photos have become profound tools for communal grief and vital public health education.
It's the ultimate elevation of a digital footprint.
The deceased person, through the digital architecture of their memorial, continues to exert a protective influence over the living. Their final footprint isn't just a record of the life they lived, it becomes an active shield for the community they left behind.
It ensures that the tragedy of the loss is alchemized into a vital, ongoing education for the public.
Which brings us full circle. We started by questioning the cognitive dissonance of placing a bright, tricolor ribbon into a somber space of mourning.
And we've seen exactly why it's necessary.
Yes, we have. We've journeyed from the microscopic mechanics of the body's master engine, that tiny butterfly in the neck, through the dangerous psychology of ignoring painless symptoms.
We unpack the rising diagnostic paradox of our modern environment.
Right, and the distinct cellular biology of 4 different enemies hiding under one name, plus the incredibly precise molecular arsenal we use to fight them.
And through it all, the through line is vigilance. The ribbon, the treatments, the digital memorials, they are all mechanisms of vigilance.
So true.
If there is a definitive takeaway from the pathology we've explored, it is that you cannot wait for the body to sound an agonizing alarm. You have to listen to the quiet, mechanical malfunctions.
Listen to the whispers.
Exactly. A persistent cough, a slight change in the resonance of your voice, a painless anomaly in the tissue of your neck. These are not trivialities. They are localized warnings of a potential systemic collapse.
Do not domesticate your symptoms. Let the clinical experts do their job.
Yes. Listen to your body's whispers. A persistent cough or a painless lump isn't just an annoyance. It's a request for your attention.
And as we wrap up this deep dive, I want to leave you with a final thought to mull over. Something that builds on the profound shift we see in these digital memorials.
It's a powerful concept.
It is. We've established that our online tributes are now acting as permanent, traveling billboards for public health and awareness. They are active agents in the world. So how might that reality change how we intentionally craft our own digital legacies right now?
It's a great question.
If we know that our final digital footprints have the power to educate and protect the people who outlive us, will we begin to design our own digital afterlives not just as archives of our personal history, but as deliberate engineered tools to protect the futures of the people still scrolling?